The headline is certainly the 24% reduction in lung cancer mortality. Unlike the NLST, they did not find a corresponding reduction in all-cause mortality, but part of that may just be because of the smaller size of the trial. In both studies, the main harm associated with screening is to have a false positive test result. And in the National Lung Screening Trial, about 40% of patients had at least one positive test result after 3 rounds of screening. And over 95% of those positive findings were false positive, so they didn't represent cancer. And so one of the goals of recent work in screening is to reduce the number of false positives or find ways to distinguish between the positive results that are cancer and that need prompt referral and the ones that are not. And one of the innovative things that Nelson did was to use something called volume measurement or volumetric imaging to basically use a computer to more accurately measure the size of the tumor. And then anyone who had a nodule of a certain size essentially was brought back 3 months later for a follow-up scan. And if the nodule was still present, it was measured using this volume technique as well. And then there was a very accurate comparison between the size of the nodule on the baseline screening test and the size of the nodule on the follow-up test. And the whole idea here is that the cancers are going to grow, and the things that are something other than cancer aren't. And in most cases, they just happen to be scar tissue, so they don't grow. So what Nelson showed is that strategy is viable, that it works. Whether it's better is still an unresolved question, but I think for a lot of patients to know that instead of waiting a year for your next follow-up test or going straight to a biopsy, to get that repeat scan in 3 months and know that the nodule is stable, that has a lot of value just to provide some reassurance.